first one is the aspirations. The first one is the aspiration cytology from the left neck level 2 area. So based on the clinical history, the patient had the cystic mass in this area, initially suspect to be cellulitis. So he has been admitted for antibiotic treatment. So he received antibiotic treatment for 2 weeks. And during the admission, he does has aspiration cytology, and we sign out it as suppurative inflammation compatible with abscess formation. So he has been treated after the 2 weeks. He was discharged, and the cystic lesion shrink. However, it still have a nodular lesion over there around 2 centimeters. So the size decreased and the cyst resolved. However, there is still a lesion. So he was admitted last month in January, and he came back to the outpatient clinic, presented with the persistent nodule. So he received a fine needle aspiration at the outpatient clinic. So in this liquid-based cytology, we see cystic background. However, some things kind of worrisome is that we do see some squamous cells. There are some keratinized squamous cells with this spindle shape. It's not particularly atypical, but we start to see some more spindle cells with like more hyperchromatic nucleus. So in this specimen, the cellularity is very low, and it shows mostly a cystic background with a lot of histiocyte. However, we start to see some like a keratinized cells. Keratin material looks a little bit weird. And then we start to see that the cell with a very long tail of the cytoplasm, it's more hyperchromatic. So in the head and neck region, we need to think about, could it be a metastatic squamous cell carcinoma, because this is the most common malignant tumor in the head and neck region. However, in this liquid-based cytology, we only have these very scattered, very scant typical squamous cells. So that's it. So if we only have these specimens, we can only sign it out as atypical, and we see a typical squamous cell suggests clinical correlation. However, in the direct smear, it does show very large cellular fragment, which is hyperchromatic. And when we go to high power, especially at the periphery of the cluster, it showed high NC ratio hyperchromasia. So this is compatible with a squamous cell carcinoma. So we have more diagnostic material in this specimen. So again, when we go to higher power, we start to see these large cells. These cells, and these cannot be benign. I think there were areas showing more definite feature of malignancy. Yeah. So we have a lot of cellular fragment over here. So I called the clinician. The clinician say that he has checked the entire head and neck region, but he didn't see any tumor. So in this scenario, the most common origin would be from the oropharynx, from the tonsil, because tonsil squamous cell carcinoma can occur in the crypts of the tonsil, which make it really difficult to be inspected. Okay, so this is super big. So this is definitely malignant squamous cell carcinoma. So it's difficult to be inspected during the physical examination. In this scenario, usually the clinician would want us to get the P16 immunohistochemistry. However, in our experience, it is mostly ideal that we can do it on the cell block instead of using the cytochemistry. Because sometimes it's very difficult to interpret the background staining if it's only done on the cytology preparation, not the cell block. So I told him that because we don't have the residual specimen in the liquid-based cytology, so we won't be able to do the P16. So he will proceed to do a needle biopsy and to do a P16 to check if it is coming from the oral pharynx. Okay. So it takes quite a while. Sometimes the clinical situation is very complicated, and the patient can be treated as infection first, and sometimes the metastasis can combine with the infection. So you need to resolve the infection first, and then to identify the tumor. So sometimes it's not very easy to evaluate the head and neck mass. A neck mass sometimes is very difficult to evaluate. So the next specimen is a pap smear. So in the background it's quite clean, and we start to see some cluster of superficial cells with coelocytic change and binucleation. So this is suspect to be low-CO, and we just need to find some more cells. So again, we do see multinucleation and coelocytic change. And here it's more like coelocytic change. So I think this is okay that we can send out this as a low CO. So that is all the case for today.